Welcome back to the Deep Dive. Today, we are putting on our scrubs, grabbing a strong coffee, and walking straight into the exam hall. We're doing something very specific for our listeners who are in the trenches of their residency, specifically those facing the firing squad of the MD anesthesiology Viva.
That's right. If you're listening to this, you probably have a stack of textbooks on your desk right now. You've got Miller, Stulting, Katie Tripathi, maybe Morgan, and Mikai. It's overwhelming. So our mission today is to take that massive stack and synthesize it into a survival guide. We're focusing on the big three non-opioid or weak opioid analgesics: paracetamol, Tramadol, and diclofenac.
It sounds deceptively basic, doesn't it? I mean, we write these on charts every single day. Paracetamol 1 gram IV, Tramadol 50 milligram. It just becomes muscle memory. But I have a feeling you're going to tell me that walking to Aviva thinking it's just paracetamol is a great way to fail.
It is the fastest way to fail. In the clinical world, these drugs are routine. In the exam world, especially for the Gujarat University curriculum or really any rigorous MD program, they're minefields. The examiner does not care that you know the dose. They assume you know the dose. They want the molecular mechanisms, the specific metabolic pathways, the genetic polymorphisms, and exactly how you'd structure a 20-mark theory answer without missing the keywords.
Okay, so we're moving beyond the what and diving deep into the how and the why. We've got a 4-part structure for this. We're going to dissect paracetamol, then untangle the weirdness of tramadol, then tackle diclofenac and the renal risks, and finally, we'll stick them all together into a clinical integration strategy. Let's start with Part A, paracetamol, or acetaminophen if you're reading the American journals.
Right, let's role play the Viva. You're sitting there, the examiner looks over his glasses and asks, "Doctor, classify paracetamol." If you say it's an NSAID, just stop talking. You might have just lost the exam right there.
That is the first trap then. It is not an NSAID.
Correct. It is a para-aminophenol derivative, specifically an acetanilide derivative. It's an analgesic and an antipyretic. The key phrase is, it lacks significant peripheral anti-inflammatory activity. If you lump it in with ibuprofen or diclofenac, you're showing a fundamental misunderstanding of how it works.
But this is where it gets confusing for residents, I think, because the mechanism does involve COX inhibition, right? Isn't that the definition of an NSAID?
And that is the nuance they're testing. Paracetamol inhibits prostaglandin synthesis, yes. But, and this is the crucial part, it does so predominantly in the central nervous system, the brain, and the spinal cord. In peripheral tissues, like a hot, swollen, inflamed knee, the environment is completely different.
Different how? What's going on in the knee?
Inflamed tissues have very high concentrations of cellular peroxides. These peroxides effectively neutralize paracetamol at the site of injury. This is the peroxide theory. It explains why paracetamol is great for a headache or for lowering a fever, which happens in the hypothalamus. But if you twist your ankle, paracetamol alone isn't going to touch the swelling.
So the peroxides in the inflamed tissue basically deactivate the drug before it can even work. That is a great answer for the why isn't it anti-inflammatory question.
Exactly. Now, if you want the distinction or, the gold medal marks, you need to go deeper than just central COX inhibition. You need to talk about the COX-3 controversy and the endocannabinoid system.
Okay, I've seen COX-3 mentioned in older notes, but I thought that was debunked.
Debunked is a strong word, but controversial is definitely accurate. COX-3 is a splice variant of COX-1 that was identified in dog brains. It's highly sensitive to paracetamol. Its relevance in humans is, it's debated, but mentioning it shows you've read the deeper pharmacology. The more modern and frankly more accepted theory involves the endocannabinoid system.
Endocannabinoid system?
Yeah.
As in the same receptors that marijuana targets?
In a roundabout way, yes. Paracetamol is metabolized in the brain into a compound called AM404 that stands for N-arachidonyl phenylamine. This metabolite inhibits the reuptake of something called anandamide. An anandamide is an endogenous ligand. It's our body's own natural painkiller that acts on cannabinoid receptors and TRPV1 receptors to reduce pain signaling.
Wow, that is fascinating. So it's not just blocking a pain enzyme. It's actually boosting the body's own chill-out chemicals.
And it also activates descending serotonergic pathways. So you have this triad: central COX inhibition, endocannabinoid modulation, and serotonergic activation. If you can put that in a flowchart in your theory paper, you are immediately standing out from 90% of the other candidates.
Okay, let's shift to pharmacokinetics. Usually this is the dry part of the exam, absorption, distribution, whatever. But for paracetamol, the metabolism section is literally life or death.
It is, and this is where the toxicity short note comes from. You have to understand the normal pathway to understand the toxic one. So 90 to 95% of paracetamol is metabolized safely in the liver via conjugation. It just hooks up with glucuronide or sulfate, becomes water-soluble, and you pee it out. No problem.
It's the remaining small percentage that's the issue then.
The CYP450 pathway, specifically the enzyme CYP2E1. It takes a small fraction of the drug and oxidizes it into a highly reactive, very nasty metabolite called NAPQI. That's N-acetyl-P-benzoquinone-PPID.
NAPQI.
Right.
That's the villain of the story.
It's a cellular toxin. Now, under normal conditions, your liver has a superhero called glutathione. Glutathione carries a sulfhydryl group that acts like a magnet for NAPQI. It binds to it, neutralizes it into mercapturic acid, and it's excreted safely.
But superheroes can get tired.
Exactly. Glutathione is a finite resource. If you take a massive overdose, usually we say over 10 grams or 150 milligrams per kilogram, you produce so much NAPQI that you completely deplete your glutathione stores. Once glutathione drops below about 30% of normal levels, the NAPQI is free to just rampage. It binds covalently to the structural proteins of the hepatocytes,
Leading to cell death.
specifically central ovular necrosis or zone 3 necrosis. You must mention zone 3 in the exam.
Why zone 3? What's special about it?
Because zone 3 of the liver lobule is where the concentration of those CYP2E1 enzymes is highest. It's the factory that makes the toxin, so it burns down first.
This leads us right to the clinical management of toxicity. If I get a scenario, say a suicide attempt or even an accidental overdose, what is the protocol?
You need to act fast, but you also need to act smart. The antidote is N-acetylcysteine, or NAC. It acts as a precursor to glutathione, essentially restocking the superhero supply. But the decision to treat is based on the Rumac-Matthew nomogram.
Which uses the plasma concentration at 4 hours post-ingestion, right?
Yeah. Correct. You can't just measure it immediately after ingestion because the drug is still being absorbed. You have to wait. You measure at 4 hours. If it falls above the treatment line on that graph, you start NAC. Simple as that.
And what about the chronic alcoholic patient? We always hear they are high risk. Is that just because their livers are already damaged?
It's more specific than that. It's actually a double hit. First, chronic alcohol use induces CYP2E1. It revs up the enzyme engine. So an alcoholic patient converts a much higher percentage of paracetamol into the toxic NAPQI than a non-drinker would. And second, alcoholics are often malnourished, so their baseline glutathione stores are already low, so they produce more toxin and have less defense.
So for them, the therapeutic window is much, much narrower.
Exactly. In those patients, we often lower the max daily dose to 2 grams instead of the usual 4 grams, or we just avoid it entirely if they are in active liver failure.
Okay, before we leave paracetamol, let's just touch on its role in anesthesia specifically. Why do we love 5-E paracetamol so much?
Because it is the foundation of multimodal analgesia, there's a concept called opioid sparing. Studies have shown that adding regular paracetamol can reduce a patient's total opioid consumption by 20 to 30%. That means less respiratory depression, less nausea, less sedation in the PCU. It's just a clean drug.
All right, that's paracetamol. Let's move to Part B, Tramadol. This drug seems to have a bit of an identity crisis. It's an opioid, but it's not just an opioid.
Tramadol is what we call an atypical opioid. Chemically, it's a synthetic 4-phenyl-piperidine analog of codeine. It sits right in the middle of the WHO pain ladder. It bridges that gap between the simple stuff like paracetamol and the heavy artillery like morphine or fentanyl.
And the mechanism here is a favorite Viva topic because it's a dual mechanism. You can't just say it binds to mu receptors.
If you just say mu agonist, you are only getting half the marks. Mechanism 1 is indeed the opioid effect. It is a weak agonist at the mu opioid receptor. But, and this is the key, its affinity is incredibly low. It's about 6,000 times weaker than morphine.
6,000 times. If it's that weak, how does it provide any meaningful pain relief at all?
Because of mechanism 2, the monoaminergic effect. Tramadol inhibits the neuronal reuptake of norepinephrine and serotonin in the spinal cord.
Okay, so for the listener visualizing this, this is happening in the dorsal horn of the spinal cord, right?
Yeah.
In the descending inhibitory pathways.
Exactly. The brain sends signals down the spinal cord to tell the nerves to shut up. These signals run on serotonin and norepinephrine. By blocking the reuptake, Tramadol keeps those neurotransmitters in the synapse longer, which just amplifies that shut-up signal.
Now, I've seen questions about enantiomers regarding tramadol. Is that too detailed, or is that fair game for an MD exam?
That's fair game. Tramadol is a racemic mixture. It has a plus enantiomer and enantiomer, and it's actually quite elegant. The plus enantiomer is the one that binds to the mu receptor and also inhibits serotonin uptake. The enantiomer is the one that inhibits norepinephrine uptake. They work synergistically. One handles the opioid side, the other handles the adrenergic side.
That is brilliant design. But this dual mechanism creates a huge trap when it comes to reversal.
The naloxone trap. This is a classic question. Doctor, you have a patient with a tramadol overdose. You give naloxone. Is the patient cured?
And the answer is no.
The answer is partial reversal. Naloxone will knock the drug off the mu receptor, reversing the respiratory depression and the sedation. However, it does absolutely nothing to the monoamine reuptake inhibition. So the patient might wake up, but they still have dangerously high levels of serotonin and norepinephrine flooding their synapses.
And that leads directly to the seizure risk.
Yes. Tramadol is known to lower the seizure threshold. In fact, giving naloxone in a tramadol overdose can theoretically increase the risk of seizures because you're removing the inhibitory opioid effect while leaving the excitatory monoaminergic effect running wild.
That is a crucial clinical pearl. Let's talk about metabolism, because tramadol is another one where the liver plays a massive role. It's a prodrug, isn't it?
It is. Tramadol itself is actually quite weak. It relies on the liver enzyme CYP2D6 to convert it into O-desmethyltramadol, which we call M1. Now, pay attention to this number. M1 is 200 times more potent at the mu receptor than the parent drug.
So you are essentially swallowing a dud, and your liver has to turn it into the actual painkiller.
Exactly. And this brings us to pharmacogenetics, which is a very hot topic right now. The CYP2D6 enzyme is highly variable in the heathen population.
Or we have the poor metabolizers and the ultra-rapid metabolizers.
Correct. About 5 to 10% of Caucasians are poor metabolizers. Their CYP2D6 is sluggish or absent. You give them tramadol, and they get almost no pain relief because they can't make the active M1 metabolite. They just get the side effects, the nausea, the dizziness, without any of the analgesia.
That explains why some patients swear that tramadol doesn't work for me. They aren't lying. They might just be genetically immune to it.
Conversely, you have the ultra-rapid metabolizers. These people, more common in Middle Eastern and North African populations, convert tramadol to M1 super fast. They can get dangerously high levels of the opioid metabolite from a totally normal dose. There have been case reports of children dying or going into respiratory arrest after a standard dose of tramadol simply because they were ultra-rapid metabolizers.
This is why the FDA slapped a black box warning on tramadol for children and for breastfeeding mothers.
Precisely. In the exam, if they ask about pediatric pain, you need to think twice before suggesting tramadol. It's really falling out of favor for kids.
Let's move to adverse effects. We know the standard opioid stuff, nausea, constipation, but tramadol has some unique baggage. Let's talk about serotonin syndrome.
This is the drug interaction trap. Because tramadol increases serotonin levels, if you combine it with other drugs that also increase serotonin like SSRIs such as Prozac, MAO inhibitors, or tricyclic antidepressants, you can trigger a serotonin storm.
What does that look like clinically?
Agitation, confusion, a rapid heart rate, high blood pressure, dilated pupils, muscle rigidity, and hyperreflexia or clonus. If you have a patient on chronic antidepressants coming in for surgery, you need to be very, very careful with tramadol.
Got it. One last thing on tramadol. It's used for shivering.
Yes, it's an off-label use, but it's very effective. Post-anesthetic shivering is miserable for the patient, and it dramatically increases oxygen consumption. Tramadol, likely through its alpha-2 adrenergic or serotonergic effects, is very good at stopping it. 25 to 50 milligram IV usually does the trick.
Okay, that's paracetamol and tramadol. Now for the heavy hitter. Part C, diclofenac, the NSAID workhorse of the perioperative ward.
Diclofenac is a phenylacetic acid derivative. It is potent, it provides strong analgesia, and unlike the other two, significant anti-inflammatory action right at the surgical site.
And the mechanism of action is COX inhibition again, but this time it's peripheral.
Peripheral and spinal, yes. It inhibits cyclooxygenase, which blocks the conversion of arachidonic acid into prostaglandins. By reducing prostaglandins, you reduce the sensitization of nociceptors, basically. You stop the nerve endings from screaming so loud. You also reduce the vasodilation and edema.
Is it selective at all?
Diclofenac is generally classified as non-selective. It hits both COX-1 and COX-2. However, some literature does suggest it has a slight preference for COX-2 compared to older drugs like ibuprofen. In some assays, it's almost equipotent to celecoxib, but for the exam, just treat it as non-selective. This matters because the COX-1 inhibition is what causes most of the side effects.
Which brings us to the big one, the kidney. Anesthetists are obsessed with renal function, and for good reason. Why is diclofenac so dangerous for the kidneys?
This is the renal trap. You have to understand the physiology. Imagine a patient who is hypovolemic. Maybe they've lost blood during a major procedure, or they've just been fasting for 12 hours. Their kidneys are stressed. To keep blood flowing into the glomerulus, the body releases prostaglandins to dilate the afferent arteriole.
So the prostaglandins are basically holding the door open for blood flow.
Exactly. They are the check valve, keeping the kidney perfused during stress. If you give diclofenac, you block those prostaglandins, the afferent arteriole clamps down, renal blood flow drops like a stone, and you can precipitate acute kidney injury, or AKI.
So the rule is, never give NSAIDs to a dry patient.
Never. Ensure they are euvolemic and hemodynamically stable first. If the patient is hypotensive, keep the diclofenac in the ampoule.
What about the bleeding risk? Surgeons are always asking, can you hold the NSAID? I don't want a hematoma.
Diclofenac inhibits platelet aggregation because it blocks the production of thromboxane A2 via COX-1. But, and this is a key Viva distinction, unlike aspirin, this effect is reversible.
Explain that difference.
Aspirin acetylates the COX enzyme permanently. The platelet is disabled for its entire 7 to 10-day lifespan, it's gone. Diclofenac just binds competitively. Once the drug washes out of the system, which takes a few hours, platelet function returns completely to normal, so the bleeding risk is transient, but it is real.
And the stomach. The GI risk. Same principle. COX-1 produces prostaglandins that maintain the protective mucus lining of the stomach. You block it, and the acid starts eating away at the stomach wall. Gastritis, ulcers, GI bleeds. This is why we avoid it in any patient with a history of peptic ulcer disease. Okay, so we have our three players. Paracetamol, which is safe and central. Tramadol, the dual mechanism drug with tricky metabolism. And diclofenac, the peripheral powerhouse with a major renal risk. Part D. Let's integrate this. How do we put this all together for a 20-mark answer or a clinical case?
You need to think in terms of the analgesic ladder, or more accurately, multimodal analgesia. The concept is synergy, using different mechanisms so that 1 + 1 = 3.
Can you give us a concrete example?
Let's take a standard laparoscopic cholecystectomy. Moderate pain. Step 1, paracetamol. 1 gram IV at induction. That handles the central component. Step 2, an NSAID. If the kidneys are fine and hemostasis is good, you give diclofenac or ketorolac at the end of surgery. This handles the peripheral inflammation at the port sites. Step 3, if those two aren't enough, then you add a weak opioid like Tramadol. And step 4, if pain persists, you use rescue fentanyl or morphine in the PPC. By stacking them, you use smaller doses of each, which minimizes the side effects from any single drug.
Okay, now let's talk about the Viva trap specifically. I'm going to throw a scenario at you. You tell me the trap. Scenario 1, an 85-year-old lady with a fractured neck of femur. She has mild renal impairment, say a creatinine of 1.4. What do you prescribe for pain?
Okay, trap 1, the renal elderly trap. You avoid diclofenac completely. Her kidneys are already fragile, and an NSAI could tip her into acute renal failure. Be very careful with Tramadol. Elderly patients are prone to delirium, and Tramadol can cause confusion. Also, with renal impairment, the active M1 metabolite might accumulate to toxic levels. The winner here is paracetamol, maybe at a reduced dose, and most importantly, a regional nerve block, a fascia iliaca block. Regional anesthesia is the ultimate non-opioid analgesic.
Perfect. Scenario 2, a patient with a history of seizures and depression, currently on fluoxetine, needs pain relief for a simple ankle fracture.
Trap 2, the serotonin seizure trap. You avoid Tramadol. You risk precipitating a seizure or causing serotonin syndrome. Diclofenac is a great choice here, assuming no renal issues because an ankle fracture has a very high inflammatory component. And paracetamol, of course, is also perfectly safe.
How should a candidate present this information visually in a written paper? We know examiners love diagrams.
You need at least 3 diagrams for this topic. 1, the arachidonic acid pathway. Draw the membrane phospholipids converting to arachidonic acid, then the COX pathway. Show where NSAIDs block, and show the split between prostaglandins and thromboxanes. 2, the glutathione depletion curve for paracetamol. Draw a simple graph with glutathione levels on the y-axis and time after overdose on the x-axis. Show it dropping. Draw a dotted line for the toxicity threshold at 30%. Show that the necrosis only starts when the curve dips below that line. And 3, the pain pathway. Draw a simple diagram of the nervous system. Show the periphery and mark NSAIDs here. Show the nerve transmission and mark local anesthetics here. Then show the spinal cord and brain and mark opioid Tramadol paracetamol here. This visually demonstrates the whole concept of multimodal analgesia.
That is incredibly helpful. Visuals break up the text and show you really understand the physiology.
Exactly. And remember the special populations heading in your long answer. Always have a paragraph on elderly, renal failure, and hepatic failure. For renal failure, no NSAIDs. Adjust Tramadol. Paracetamol is generally okay. For hepatic failure, no NSAIDs because of bleeding risk and hepatorenal syndrome. Caution with opioids due to encephalopathy. And paracetamol is actually safe in stable chronic liver disease at reduced doses, like 2 grams per day, but it's absolutely contraindicated in acute liver failure.
That last point on liver disease is a nuance people miss. They just think liver disease means no paracetamol ever, but it's actually about the dosage and whether it's acute versus chronic.
Correct. In the exam, nuance wins, blanket statements lose.
We have covered a massive amount of ground today, from the molecular binding of NAPQI to the genetic lottery of CYP2D6.
The key takeaway for the listener is this. In the exam, always relate the pharmacology back to perioperative safety. The examiner wants to know that you can use these drugs safely in an anesthetized, vulnerable patient. Don't just list facts. Explain why you would or wouldn't use a drug in a specific clinical case.
Before we sign off, do you have a final provocation for our listeners, something for them to chew on?
Yes, a thought for the future. With the rise of pharmacogenomics, we are already testing for things like malignant hyperthermia susceptibility. How long will it be until we're testing every patient's CYP2D6 status before prescribing Tramadol? Given the variability, where some people get zero relief and others stop breathing from a normal dose, it's a question worth asking. Is the one-size-fits-all dose of Tramadol on its way out?
That is a great point. We titrate our volatiles, we titrate our muscle relaxants. Maybe we should be titrating our prodrugs based on genetics. You've got the notes, you've got the traps. Now go write those answers. Good luck with the exam.
Good luck. Go ace it.
See you on the deep dive.